So let's for the moment assume in our world, everyone can afford a house. Let's assume for the moment that all homes are accessible, but she mentioned a problem that we haven't solved, and that's the health and social services to stay in your home. So I'm delighted that we have a great panel here today. To my right, Dr. Terry Fulmer, thank you for being here. She's with the Hartford Foundation. And I want you to kind of introduce yourself and what you do.
Sure. So Terry Fulmer, president of the John A. Hartford Foundation in New York City. Our foundation is dedicated to improving care for older adults. Our money is from A&P grocery stores.
And then to her right, Seth Sternberg from Honor. He's the co-founder and CEO of Honor. Tell us a little bit more about what your company does.
Yeah, so Honor provides in-home care to older adults. So it's ADL supports, activities of daily living. In this crowd, I probably don't have to define ADL. We built a technology that allowed us to actually scale home care and keep growing and provide higher quality care to people in their homes where they live. A little while ago, we bought Home Instead. So we started infusing our technology stack into the Home Instead network. So as a complete network now between Honor and Home Instead, I'm pretty sure we're the largest non-medical private pay senior care network in the Western Hemisphere. I don't know if something is larger. So take care of lots of people in their homes as they're aging.
Thank you. So my first question really is, what do you think the biggest barriers are to people aging in their homes today?
We practiced. Seth is going to go first.
Oh, great.
Okay. Yeah, so I would say number one barrier really is affordability, right? So when you look at in-home care and you look at where people are getting care, a very small microslice of people can afford private pay non-medical home care like what we do. And then you have folks where Medicaid does provide some supports for in-home ADL supports. And then you have everybody else in the middle. And everybody else in the middle is getting care from neighbors, family, friends. But that's really hard to piece together, and it's a burden on society. So I think really the biggest challenge is that affordability. And I'd say the second one, and I'll pass the baton, is when you look at the structure of our industries around caring for older adults in their homes, they are all hyper fragmented, like at an absolutely ridiculous level. And this goes for private pay ADL supports, which is the most fragmented industry. It also goes for home health. It goes for hospice. Like the big players might own 5-7% of the market, which means it's hyper fragmented. And that is because we have not invested enough as a society and invested enough in kind of the technology to figure out how to defragment those industries. But if you defragment them, you end up with better care and better jobs. If you get better care and better jobs, then you're really solving a societal problem.
Yes. And so let me ask, how many nurses are in the audience? Raise your hand, please. One.
Oh,
welcome.
Thank you.
Okay, so what are we talking about here fundamentally? There are over 50 million family caregivers in this country saying, what do I do now? We send people home with tubes, strips, and drains and say, good luck with that. Good luck with that. How many of you have had to do that? Many people. Okay. And so we have that many family caregivers. And the other thing we have is we have a very fragmented, as what Seth said, post-acute system in this country where if you happen, and it's all about payment structures, 100% about payment structures. If you happen to fracture your hip and after you are able to be discharged, you will go to a nursing home and your care will get paid for because that's the structure of payment. You may not want to go to that long-term care facility, but if you want to get paid by CMS, that's what you have to do. And so if you are well off, then you can decide to get your care at home. So again, what are we talking about? 55 about million older people over 65. And so how many people are in nursing homes? Anybody want to guess a number? Guess, and not Ken, he knows. How many people? 1.2 million. Of those 1.2 million, about 500,000 of them are rehab people who are transient, they're going through. And about 500,000 people need long-term care, skilled nursing. You're gonna see my reaction here. During COVID, our foundation, dedicated to improving care for older adults, immediately funded a urgent study by the National Academies on improving quality and safety in nursing homes. We started a daily nursing home huddle. We worked with a number of organizations and agencies around the country who could get to people who were homebound and couldn't get their vaccinations or food or anything else that they needed. So all that said, how many people are in senior living? About 1.2 million. How many people are in assisted living? About 800,000. Are you hearing how small the numbers are? How many people are in PACE? About 67,000 people. We've been talking about PACE for 30 years. Everybody loves to talk about PACE, but PACE isn't scaling. That's why we need Seth. And what we have to do is ask ourselves fundamentally, why aren't we doing this work well? And it's because of rampant ageism. We love to save people. We love to say, okay, you've just had a cardiac arrest. We will bring you back. We will bring you back. And you will then, continue your life. You have cancer, we'll give you chemotherapy. We have biologics, we'll bring you back. But we fundamentally do not like to then take care of people who have lost function because they have now entered into a new phase of their capacity to be functional. We pay for things one disease at a time. I work with a group called the Society to Improve Diagnostic Medicine. Anybody ever hear of them? Think of the title, Society to Improve Diagnostic Medicine. We would like the right diagnosis. Wouldn't that be handy? That would be a really good thing. We'd like the right diagnosis. We don't always get it. But when you do get that right diagnosis, then how do we make sure that it lines up with all your diagnoses? So if my grandmother has congestive heart failure and she happens to have breast cancer and hypertension and some renal failure, she might be going bowling tomorrow, but that's what she has. So we have to begin as a group to think about function and not numbers, think about capacity, and think about how we pay for care. It shouldn't be one DRG at a time, please. If you tell me one more time about the DRG payment and what's happening with that, that's not sustainable. All of us can think about function, think about the way that we think about this more holistically, and that's going to help family caregivers. Let me go back to my point and then pass it back to Amy and Seth to say that of the 55 million people who are over 65, there are very few that are getting the type of support, caregiving that they want and need. 90+% people want to be at home. And we also know that 70% in a recent study that we did say that under no circumstances are they ever going to a nursing home. So people have strong feelings, but they don't always get to live the way they want to because of the structure we have in place right now. So there comes Seth with ideas.
So, and so this is actually something that we think a ton about. So we've done our own little studies and work on ADL supports, private pay home care, how many people are paying for it annually? And the answer in America is probably about 2 million people annually who pay for it in some way, shape, or form. And then you look at how many people are older adults who would actually need care and how many people are piecing together, like I said, friends, neighbors, et cetera. And so one of the reasons that we actually started on the way we did, like outside of the core healthcare ecosystem, is that it is a space where we are not dependent on someone else paying for innovation, but rather our clients are paying us to serve them. And then we can take the profit and reinvest it to try to fix other things, and we get to make that choice, right? And so when I think about the number one thing that we have to fix, like in today's world, it's actually defrag. You have to defragment this hyper-fragmented industry, because without doing that, you don't have enough scale to start bringing costs down for clients while you're still providing good jobs to care pros. But if you have scale density, you need technology to get that, right? Like you can't do routing people all over the place to go to tens of thousands, hundreds of thousands of homes without technology, right? That doesn't work. So you need technology to do all that routing. But if you get that scale and you get that density, you can then start thinking about, okay, well, how could I start really meaningfully bringing the cost down to my end consumer while I maintain a good job for the care pro. And see, as an entrepreneur, my basic perspective in life is I can't rely on anyone else, right? It's just no one's going to do it for me. And so the insurance companies are not going to do it for me. And the government's not going to do it for me. We have to figure out the solution to how to provide lower cost, more accessible care in people's homes to people who need it. And for us to get there, right, we have to go through what I consider to be a really long process of scaling and building the technology stack to get to the point where then we can start working on this like really important societal problem of getting affordable care to kind of what you would call the middle, right, to the vast majority of people in this country.
I read a statistic recently that said that about 47% of family caregivers are now male, which is extraordinarily different than it has been in the past. And I think that that's a very good start. And when I started my career, I used to say I could double the number of caregivers if I could double the gender. And everybody would laugh. It's not funny. I was really serious. And I'm really happy to see that we're beginning to get some gender equity there. And that's important. So when I think about that also, I think about what is the government doing? Well, the RAISE Act was passed. Anybody ever hear of the RAISE Act? So that, yeah, so that was several years ago now, and it's the recognize, assist, interact, support, and engage caregivers, and that has led to an organizational shift toward supporting family caregivers and ultimately trying to get family caregivers paid for the work that they do. And you're seeing some very tiny inroads into that now, which could go one way or the other, depending on what ultimately goes on in Congress. But this is a bipartisan issue. And if ever there was one, everybody has an older person. You know, if you ever listen to Rosalind Carter talk about you either are one or you need one or you're going to be one. So thinking about the way in which we work with those types of programs in government and help move them along is really, really important. And speaking of government, I said to Seth before we came in, does Medicare pay for honor? And the answer to that is no. And so when we see our government begin to pay for programs like honor, we'll know that we're on a path of spread and scale and sustainability, which I look forward to. Yeah.
I want to go back to your comment about the forgotten middle and the affordability issue of caregiving, and also pull on what you were talking about, the equity that is coming with family caregivers around gender. But what we're still not seeing, I think, when we talk about paid caregivers is this recognition that they are mainly women of color. What are they getting paid? I know you both have done work in this field, and just talk about that a little bit.
Do you want to start?
So one of the top things that we've, like, literally when we launched the company, we internally used the phrase care for the care pro. So the first thing we did is we interviewed like 50 we call them care professionals, paid caregivers at Starbucks in Sacramento and Phoenix. Those were our two chosen markets. And we asked these almost all female caregivers, paid caregivers, you know, what matters to you, what's happening in life, et cetera. And one of the number one things that we heard is, I'm a professional. I think of myself as a professional. I want to be a professional, but I'm treated like crap. And so when we were flying home from Phoenix, we came up with the term care pro, care professional. And the idea was, we're going to at least start by calling paid caregivers what they want to be and how they see themselves, which is professionals. And so that's why we said care pro. And then as we developed the company over time, and we literally thought in terms of care for the care pro, we began to recognize that there is actually a lot more to caring for the care pro than what is the hourly wage. And this is something that I think almost everyone misses. And it's a nuance that doesn't get covered well in the media, so it doesn't get talked about. But there's this reality that, like, you're a care pro, you have 2 clients this week, one of them passes away. Do you take a 50% pay cut next week? Well, if you do, that's like devastating, right? So stability in your hours matters a lot. Or you're a care pro, you're being sent into a home, there are not good notes about the client's condition, who else lives with that client, does their son-in-law live there too, et cetera. And literally when you talk to care pros, you find out that walking into the home is often literally scary. Like literally they have fear, right, over stepping into the home. So as I could tick down a list of probably 100 of these insights that we've had over the almost decade that Honor's been around now. But when we think about Care for Care Pro, one piece of it is hourly wage, but there are many other pieces that are super important to create a true profession out of this. And a lot of them have to do with giving people the right job for their skill sets so that they will be successful, right? You can literally think of it as a profession. Like, how do I train you? How do I put you in the right environment where you will be successful for your skills? Like you stick me, I was talking to Richard about his kids in LA and they're writers. And it's like, I would fail in that profession. So if we put a care pro into the wrong home for their skills, they will fail. None of you want that, right? So they don't either. Giving them the right incentive systems, like, hey, you're doing a great job. You just got leveled up, right? So truly treating care pros as professionals goes a long way to making it a true profession that people want to be in.
Yeah, one of the things I like a lot is we're shifting the word workforce to care force, which humanizes it a great deal. I think that's a really good idea. And nursing assistants, the National Nursing Assistant Association has really claimed that as an important way of thinking about the work that gets done. So I think that, remember that the pay is important, and rarely do you get to $20 an hour. In some cities or states you might, but rarely. And then benefits are not there at all for individuals who take this work on. And there's also an enormous industry for people who they're not citizens, and they're at risk all the time, and they are always in need of hiding the work that they do. So that's another element that makes it quite frightening. So, yeah.
Thank you. Let's shift gears to technology. It's easy to ask Seth about what role does AI or tech play in aging in place, but also in
Sure.
healthcare now with virtual and telemedicine. Yeah. Let's talk about how technology can change the way we age in place.
Yeah. Well, I'm a big fan of apps, avatars, robots, and if you go online and look at YouTubes from Japan, for example, they are so far ahead of us, it makes your head swim. And I think that it was several years ago that I visited Taiwan, and they were also so far ahead of us. So in certain countries where you have an inverse pyramid of aging, where you have much fewer younger individuals and older individuals, you're seeing an acceleration. But I think that the opportunity to use all those different technologies is exciting. And some of my colleagues in nursing, I am a nurse, will say, well, I don't want that. It may take away from my job. And I would remind all of us that it frees you up for all the other things you could do. So if you happen to be in home care and you run out of pads that you need, or you run out of bandages that you need, you have to stop what you're doing and go get it. There's nothing that helps you kind of pre-plan and get that accomplished. If you're in a hospital, for example, watch how many human beings are carrying trays and moving laundry around. Really? Is this really how we want to be using this incredible resource called humankind? I don't think so. And I think we can meet that challenge.
So let me talk about AI for a second, because it's like a hot topic at the moment. And I want to talk about how we have used AI and how we are using the new LLM stuff. So let's talk about kind of AI from when Honor was started. So we're at like month 18 of the company, and we're at about a $10 million run rate at that point. To give you a sense, like right now in America, I think we do about $1.5 billion a year in America alone of home care. So we're at 10 million at that point. And we're literally on the verge of just deciding we're going to shut the company down. It's just like, it's impossible. Like there's no way to wrangle the problem of like, why will this care pro not go serve that client? Why does this client love that care pro, but this other client doesn't love that care pro? Is the care pro good or bad? It was just like an intractable problem, and we were going to have to give up. Okay. And what we fortunately, when we hit that point of $10 million in kind of business, 18 months into our existence, we had enough data to start doing real data intelligence to answer these questions. So we stopped trying to answer them here, and we started to try to answer them in data. And we started to see the patterns because basically the data told us the patterns. We could not intuit the patterns, basically because our clients are heterogeneous, right? They have unique desires, they have unique conditions, they come from unique cultural backgrounds. They like different care pros. And then different care pros have different skills. They have different demands on their lives. Some can drive longer distances, others can't. Some have certain skills, they have other skills, et cetera. And matching all of that turns out to be one massive data problem. And so early on, we recognized that because of the heterogeneity of humanity, because we're all so different, we had to use data science and AI, right, in order to do the matching and figure out which care pro would be good with which client. Because one of the things that you want to do if you want to create a good job for a care pro is you want a steady relationship. And it turns out the care pros want that, and it turns out the clients want that. Everybody wants stable. So that's a good example of something that we did early on, like literally without AI. The version that everybody was using kind of like 7 years ago now, we would have shut down. If you fast forward to today, we're talking about AI a lot because of LLMs, right? Large language models, and that's the new kind of AI that everybody's excited about. So I'll give you a sense of kind of one of the exciting ways that we're using that today. So you have a new client who's about to start care, and you ask them a whole bunch of questions on an intake form to try to figure out kind of who is this person, and out of that, you want to both figure out who's the right care pro, and you want to figure out how to generate a really good care plan for this person, okay? And we realized that, we probably have like, I don't know, hundreds and hundreds of thousands of care plans that have been generated off of interviewing clients at this point. And no single one of our humans has talked to and can remember those hundreds of thousands of people, but our machine knows all of them, right? And so with an LLM, you can actually take that interview from that client and automatically generate a care plan. And you still have a human review it, but I guarantee you that that care plan is going to be more comprehensive because that machine has seen more cases of like what is the right care plan for this person than any human can hold in their head, right? And so this is, and what's very important to Terry's point is this is not replacing humans, right? It's having machines do what they're better at, humans do what they're better at, and then there's actually more people that you're serving, and so there are actually more jobs for the humans, right? And that's incredible. Like you get to that place, you're serving more people more efficiently at lower prices while you're creating more better jobs. That's like panacea, right? And you have to keep working on it and keep improving the system to ultimately be there.
In the midst of all this, there is enormous medicalization and regulation of things that don't need it. And here's my favorite example, and Don Burke loves to talk about this one. If you take your pills every day, good for you. But if you get home care, we will take the pills away from you and hand them to you. There's something out of whack when we think about the way that we medicalize the things that we're trying to accomplish. So how do we bring back some common sense in the midst of safety and quality? And what will we do moving forward? And I do believe that AI is going to be incredibly helpful to that end, but it does not make sense to just super regulate every human being into a knot where they can no longer do things or do them honestly. If the nursing assistants and home care people I work with, are you allowed to give a pill? No. Do you do it? Sure, but and so there's a wink and a nod going on because they are not going to abandon these older people and leave them in an unsafe spot. So I think that having those conversations in a more open way so that we can begin to solve for the problem would be really helpful.
I hope everybody, and if there are any regulators in the room, please, for the love of God, listen to what Terry just said. I mean, this is a huge issue, right? Like, so you send a care pro into a home, and like this client is in need of something, but regulatorily they're obvious. It's like painfully obvious, but they're not allowed to do it. It's like for dosing, well, they can guide a hand, right? I'm not kidding. They can guide a hand. and that's okay. And then we actually have to be, and this drives me nuts, we have to be particularly careful because we're large, right? Since we're large, we're more likely to be targeted. So we are like really strict about the rules because we have to be. But then people end up not getting the care that they need because you have these like gray matter regulations that just do not make sense. And the one other thing I'll say on this, because this is an important area, like you have to think about the edge cases. So we launched a product really early in our existence, which was like an attempt at lower cost care. And it was, we'll let you buy 1 hour of care from us, which the industry does not support. Like the industry will not do 1 hour of care because no one can make it work without technology. So we send care pros into homes. People are using us in like really low wage situations, which is awesome. But then we run into this really interesting problem where people are buying too little care for their mom or dad. And we ran into a situation where like a care pro would go into a home and a person's been in bed all day. Their sheets are soiled. They need a shower. They need to be cleaned up. The laundry has to be done. The family is basically outsourced intellectually care to us, but at not enough time. And our care pros refuse to leave. Like they just would not leave the home, right? And so it turns out that when you want to do something good for society, we were trying to do something good, right? Like let's let people buy just 1 hour of care. You have to think about and actively explore the externalities, both the positive ones and negative ones. And if you run into a negative one, you have to deal with it. And I would argue some of the regulations that we have today have a lot of negative externalities, like the meds.
We haven't talked about people who have cognitive impairment living at home and that very delicate personal balance between what is something that is within the realm of family caregiving and caregiving by programs like Honor versus what isn't. And that's going to be incredibly variable, but Ken has reminded me many times that to solve for this is probably not the issue, just to cure Alzheimer's is the issue. And that's always what Ken says, and I couldn't agree more. You have to cure it. You have to stop just trying to inch along. But in the meantime, my foundation takes care of people who are older and sick. And so we are working with Dave Rubin at UCLA and the wonderful care models that he has for dementia, and CMS has picked some of that work up and they're beginning to pay for it. And CMMI, the Center for Medicare and Medicaid Innovation, is, I'm sure, looking to Seth for good ideas. And so I want to shine a light on those wonderful government agencies who against all odds are making progress and moving toward what we need to see, which is logical continuity of care across settings and making sure that we are respecting and engaging and honoring and supporting family caregivers and helping them in a way that is going to be only more and more important. Last point, our public health system, which we have gutted over the past 30 years. We need to bring that back. We need to make sure the public health system has support. Our community health workers, who, if I have a cabin in the Adirondacks and the first responders, if I have a health problem, are the firemen and the EMS individuals who will then drive an hour and a half to Utica, New York, where maybe they'll be able to take care of me and maybe they won't. But thinking about every single piece of the link and supporting them along the way is essential. And this is not about emergency rooms and ICUs. This is about each, starting with the family caregiver and the support systems for family caregiving, and making sure that we also have a conversation with them saying, if this happens, then what? Last point I'll make, I think, is that I have a personal concern about 911. We have made sure everybody knows 911, and I understand why. I think it's really completely understandable. But we haven't said to people, if you dial 911, this will happen. And so we're beginning to see different numbers. What's the newest number? There's like an 811 or something like that. Thank you. But 911, whether you have 55,000 advanced directives on your refrigerator or not, may well get you intubated and into an ICU. So please have advanced directive conversations with your staff, your families, your friends, your organizations, so that people can say what it is that they want, so that family caregivers know and can act on that, particularly people who you bring into the house, Seth, who are saying, uh-oh, what do I do now, right?
Seth, final words from you as well?
I'm just really glad that everybody's in, in this room, that you are obviously here, you're passionate about this issue. The one call to arms that I think I would do for you, I think societally, we do not do enough, I mean, each of us as an individual, to work on really, really difficult, hard societal challenges. Like we've gotten out of that business. And I think historically, we have been in that business as a society, as a country. And so if I could, make one impassioned plea to everybody, it's kind of like, what is the thing that you're going to work on, where you're going to go and say, hey, I'm going to make this like truly fundamentally better in society. And I suspect a lot of you, because you're here, are doing it, right, in this space. But then also ask yourself, like, who can I influence, right? And to make these kinds of big changes takes risk, right? You're likely to fail. You're likely to run up across roadblocks. People are going to tell you it's a bad idea or it can't be done. But like, punch through the brick wall, right? And make big change in society. It is like worth your time. And that's what we like all actually desperately need right now, I think.
I love that.
I do too. On that, thank you. Thank you, Seth. Thank you,
Big
Terry.
idea.